Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast. My name is Terry Fletcher. We are at the 144th episode this week, and I'm bringing you the latest in what is happening on the healthcare platform. So we've actually had a pretty big week when it comes to alerts and things going on, and I wanted to give you some insight there. But today my topic will be getting back to basics with our patients, with our providers, and really with best practices in our documentation, our coding, and our communication. I'm just noticing that things are kind of falling apart. You know, during the pandemic, everybody's been so focused on COVID that you're kind of letting some things slide, and it's really showing. I've picked up several clients this week for audits and my original clients that I audit for, and I'm like, what is happening? So, and there's also been some other phone calls and correspondence I've got that I just want to make sure that you're aware of, and so you can also talk to your patients. And saying that, the OIG also just announced that telehealth is on their audit work plan starting August 3rd. So that means that they're going to be not only asking you for records to prove that you had audio and visual visits when billing office visits, to prove that you had time documented when billing phone calls, but they've told me that they're also going to query patients. And so this has been just a huge controversy, mainly because, you know, everybody's pushing to have the flexibilities made permanent. And luckily, Medicare isn't folding to the pressure without at least doing some due diligence, without first saying, okay, well, let's just see how effective it is. Let's query some patients and providers and see if, you know, this is more of a stopgap. Because even though they are hearing from some providers as it's been a godsend, and it has, they're also hearing more from vendors and more from associations, seeing that the payment parity is great if we can do things that are remote and get paid the same for it as if in person. And that's just ridiculous. So in my opinion, I just think that trying to say that you can get the same amount of money when it's not a pandemic for an in-person visit is really just, you know, pushing the envelope. So, and if you ever want to talk to me about that, I'm happy to talk to you about that. But you just can't do the same kind of exam. You cannot find the same things in a patient. You know, it's what the patients don't find that is really something to consider. You know, they don't know that there's a hard nodule, you know, in their thigh area. And so, you know, that could be Hodgkin's lymphoma. A friend of mine recently, she was in person at her dentist when finally dentists were able to open back up, and they found a node on her lymph, and she has thyroid cancer. Now, she found that at her dentist's office. She would never, ever have been able to see that from a virtual visit. And so there's things like that you have to really keep in mind when, you know, people are trying to push for all or nothing telehealth. I believe that it's appropriate, absolutely, in you know, 50% of the cases that we're dealing with, but you're going to be audited for it now, and I want to make sure you're aware of that. The other thing that I thought was interesting is I had a recent call from an ambulance company, and they said, hey, Terry, we listen to your podcast while we are on the road. And I'm like, you do? And they're like, yeah, we love it. I'm like, okay. But they said we had a comment. If you wouldn't mind telling your listeners to talk to their patients, because I don't think people understand what an ambulance service is for. And actually, I was talking to my daughter's boyfriend about this, who's an EMT, and the same situation or same conversation was had. Basically, he said, you know, patients don't realize that you don't call an ambulance service to get a prescription refilled. And a lot of patients have been doing that. Unless it's life-threatening, you can't call the ambulance service. First of all, it's $2,000, and if it's not medically necessary, it's not going to get paid. Secondly, the ambulance service only gets paid for transport time. So if they have to wait longer than its 18-minute threshold, you get left there. Talk to your patients also and let them know this is not a fast pass to go to the front of the line in the ER. If the nurses see you come in and you're fine and you're not in an emergent state, then they'll sit you in a chair for 5 hours. So ambulance services are only for life-threatening situation, not prescription drug refills. And you really need to talk to your patients about that and let them know that unless you're having a medical emergency, calling 911 for an ambulance is not appropriate. And this is where you really need to consider those care management services, because that's where they can, have that monitored, have that access, and you can get paid for it. And you're not getting those readmissions, and they're not getting those hefty bills on calls and then trying to blame your office for it. So, getting back to basics, talk to your patients about and have some communications with them. Even if you're not in the office, you can still talk to them over, telehealth. So really try to have those conversations. I know it's tough when we're not in the same room, but with everybody, and if you haven't completely opened up yet, but that's important. Also, and I was really trying not to talk about telehealth today, try to limit your waiting room times, your virtual waiting rooms. I am hearing such horror stories of an hour to an hour and a half, and patients will either hang up or they'll do something else. They'll forget you're there, but that's not right. You can't be similar to in person. Make sure that you are scheduling and blocking those times and reminding your physicians to get off the phone, get off the phone and get off the video call and move on to the next patient. They're waiting, and it's important that we really keep this an efficient way of delivering service. If you get a chance, go to icd10monitor.com and read my article this week on telehealth fails and successes, and tell me what you think, because I brought up a lot of points that I hope is somebody's listening. Now, I know AHIMA picked it up. Medicare actually picked it up, and I saw it retweeted by somebody in the Senate when they're talking about things. So I was like, okay, well, governments are watching. So it's something to really consider and read about. So let's get back to basics on some of the things with documentation. And we forget, as we are looking at just some simple services, and as we're going to move into 2021 soon, this is really important to, at least from a documentation perspective, looking at assessment and plans and really having best practices when it comes to clarity on some diagnosis coding. I think we forget some of these things. So for an example, documentation can be improved in your assessment and plan if you have, for example, here's a common example I'll see diabetes, hypertension, osteoporosis, status post coronary artery bypass graft, CABG, and sometimes they will give a date and sometimes they won't. That's actually a pet peeve of mine. If you're going to refer back as one of the risk points on a patient on a recent or not so recent but relatable surgery that they just had, you want to make sure that you have the date of that surgery listed in that plan of care or in the HPI if you're referring to it there. You don't want to have the reader or auditor of that medical record documentation having to go searching for it. So it's not helpful. So what I see is that list, and then I'm like, okay, so what's happening? And what would be better, or best practices example, would be to say type 1 diabetes, no changes in medication at this time. We'll check A1C in 3 months prior to the next visit. Or hypertension, stable on Cozar 30.5 milligrams with no changes in dosage. Migraines followed by Dr. Jones. Current medications are not affecting the hypertension. Something like that. And with this best practice assessment and plan or medical decision making, you know exactly what conditions the patient's been diagnosed with and what the treatment plan is. Also, it's helpful in the assessment and plan if the physician can explain what was found, what labs were performed, the x-rays or other services that were ordered and performed, and expected outcome by the next visit. Also, the return to clinic date is really big for me. If I don't see one in there, it doesn't look acute to me. So the acuity is lost on that, and that's going to be an important aspect as we move into 2021 as well. So let's talk about the ICD-10 coding and documentation, for example. So here's just some principles. And again, I try to get into what I call best practices to really help craft a stellar medical record document. So principle, and these are just some principles I like. Number 1, clarity. The documentation should communicate to all readers of the document what the intent is of the provider that is documenting. Then it should be concise. The documentation should describe each diagnosis succinctly and to the highest degree of specificity. So make sure that if it's sign or symptoms, but they relate to a specific diagnosis, that you're not also coding that. You can put that in to start, but then you wouldn't code from that. Consistency is key. The documentation should avoid conflicts or contradictions with information throughout the record. So if a physician is still using a voice recorder or a voice-activated dictation system, they need to make sure they're speaking into it clearly. Otherwise, you may have some inconsistencies. With the recorder, sometimes they don't pick up on voice recognition, or the provider might say he when it becomes she, and now you have a gender conflict. I had that twice already. And the patient was actually being seen for impotence and for prostate cancer, and it showed that it was a she twice throughout there. And I'm just like, okay, people, we need to get this right. Otherwise, it's a query, and do you really want to ask a physician if you meant he or she on a prostate patient? When it comes to querying a physician, so many physicians don't understand what risk adjustment is, and we really don't expect them to, because risk adjustment is a method of the offset, or the method to offset, I should say, the cost of providing health insurance for individuals such as those with chronic health conditions who represent a relatively high risk to the insurer. That's why there's risk adjustment models. That's why we have hierarchy codes. So to have your physicians take the query to heart, they need to make it as if you are questioning their clinical, sometimes they make it as if you're questioning their clinical knowledge or medical decision making. So be sensitive to that and point out that's not what you're doing, that you're just trying to capture the most accurate documentation within the note to support the codes that you're putting into the chart. Say, because I have your back, and I always like to say that to a physician, I have your back, but only if I can support it. If I can audit it and be successful at my audit, then I'm happy to do whatever you have in there. But if I can't, you're going to get a query. Then another principle would be completeness. The documentation should include all of the conditions evaluated and treated. You're going to hear the word addressed next year. And so, as well as all chronic or other conditions that affect the patient care, any treatment or management on those conditions. The documentation should also include the date of service. That seems to be a no-brainer. The patient's name, the provider's credentials, and a timely signature. Sometimes we're not getting that still. Legibility. Now, some of you still have paper charts. I'm auditing them, so I know you do. But the documentation should be completely legible to any objective reader of the record. So even if you're not on EMR, you still have to be able to read it. Specificity. It's more important than ever to be specific with diagnosis codes. The more specific you can become, then those pieces of that pertinent information are very helpful to the payer should you actually be asked for an audit. So some of those pertinent pieces would be type or morphology, site, any kind of laterality or specific location within the patient's body, any temporal parameters, severity, causality. So, the causal or the link to that service or that diagnosis, episode of care, if there's a remission status, any complications. You want to avoid terms that imply uncertainty. So if you can get your physicians to stay away from things that say probable or apparently or it's likely or consistent with, to describe confirmed diagnoses. So you should not document uncertain diagnoses, as I mentioned before, if they're actually confirmed. Instead, providers should document the sign and symptoms in the absence of a confirmed diagnosis. And then timeliness and dates. I don't know why this is so hard for people. So be very specific, because this information can affect diagnosis code assignment, but it's also important for the physicians to understand that the documentation has to be specific and has to tell a story of what's going on with the patient. So, for example, let's talk about acute MIs. So for an MI that is equal to or less than 4 weeks old, requiring continuing care, you would look to the codes in category I-21, and then they've got extra digits. That's an acute myocardial infarction. Then for MIs, again, these are heart attacks, that are after 4 weeks, but still receiving care, you would look to the appropriate aftercare code. And for MIs that are healed or old or requiring no further care or workup, you would report old MI, which is I-25.2 category. So if your cardiologist, for example, documents follow-up office visit for recent myocardial infarction, this is kind of vague. So you need more specific examples. So something like hospital follow-up, discharged from cardiovascular medical center on 7/4/2020 after inpatient admission on 7/1/2020 for acute myocardial infarction. That's helpful. Or hospital follow-up, discharged from, again, cardiovascular medical center 1 week after implantation, inpatient admission 2 days prior for acute myocardial infarction. So being more specific and really trying to understand where your physicians are going with that is going to be really helpful. But they're trying to also give detail to a reader and to an auditor, detail in the chart that, especially if they're doing this during telehealth and during an audiovisual visit, you're not actually seeing the patient in person. So if you can give detail based on what you are reviewing from them, based on where they're at within their progress or deterioration of their condition, that's going to help you support those levels of service. And I think that's also what Medicare and OIG could be looking at when it comes to documentation, because it's really been lacking. So that's going to be a problem. So my coding question today, since I seem to be stuck on cardiology, let me do that. I actually miss my cardiology coding. So I've been doing a lot of chapter presentations for local chapter APC, local chapter HEMA, and some of the state AMA associations. So that's been kind of fun lately. And not just cardiology. So most of you know I am multi-specialty. So if you're ever looking for that, let me know. But here's a question reporting something called Mobitz block type 1. How do you do this? So my cardiologist, this is a question from one of my Texas Coding Corner clients. My cardiologist documented a diagnosis of Mobitz block type 1. Which ICD-10 code should I report? Okay, whenever you hear something called Mobitz block or Wenkenbach's block, usually it's named after somebody who found that particular diagnosis or found that particular problem. So you should report I-44.1, that's an AV or atrial ventricular block, second degree, for Mobitz block type 1. If you look under included conditions for I-44.1, you'll see that this includes types 1 and 2 AV block, types 1 and 2 Mobitz block, and types 1 and 2 second degree block, and also Wenkenbach's block. And it also defines it a little further. Heart block or AV block, this refers to the impairment of the electrical signal from the heart's upper to lower chambers. So in a second degree heart block, some of the signals from the atria don't reach the ventricles. So basically think about it as a computer, that the battery of the computer isn't getting juice to the leads, or I should say the connectors to the heart. And this results in a skipped beat, which is typical of type 1, or a slow beat, because again, the juice isn't getting there, which may require a pacemaker, and that's typical of type 2. So just a little anatomy lesson there when we talk about the computer of the heart. Our coding question was brought to you today by Charles Schwab Corporation. Be a more informed investor. Follow us for news and insights to help you. Hashtag own your own tomorrow. AboutSchwab.com. So my personal tidbit this week is actually probably funny to some of you. I'm following up on my Napa trip from last week. Okay, so my daughter Summer and I, who's 25, we went on our Napa trip. We were in the middle of our 7-hour road trip on Wednesday, and we get an alert on our phones that says all indoor seating is now shut down. And so remember, I think I mentioned that everything outside, only Napa County was safe. I should have known better. So they said the weather was going to be 90s. We're already about 4 hours into our trip. We both look at each other. We're like, you know what? We need a day away. So we get up there, and we're planning on being there till Sunday. And we're fine. You know, it's about probably 85 as we're driving, but, you know, cars, air conditioning, whatever. And so we get up there, we check in the hotel, we grab something quick to eat, and then we go to our first winery, which is outdoor seating, lots of shade. They have a water feature, so you kind of feel like you're being misted, but it's hot. It is very hot. And I drink only red wine, which is room temperature. So that's like, okay, that was a little warm. So we go back to our hotel. It was a long drive. So, you know, it's air conditioning. So we each had our own room, thank God. And so then the next day it was supposed to get up to 95. And we started out early, first got a little bubbly, then went to another winery called Turnbull, which is my favorite. That was also outside, but they had a lot of greenery. And so it didn't feel too hot. It felt about 80. But then we went to 2 more, and by the time we were done with 4 wineries, it was 101. And we were both supposed to go to a really nice restaurant for dinner, but again, only outdoor seating. And we both looked at each other and like, No, let's go get something cold through a drive-thru and get back to our hotel. And so at 3 a.m. on, I guess, Friday morning, we basically looked at each other or texted each other from our rooms and said, are you ready to go? Are you awake? And I was so awake. I was checking my phone. She was awake, and we packed up and left and got home by 10:30. But it got up to 102 that day, so we're glad we left. It was nice to get away for a bit. I hope everybody tries it at some point, but try something a little cooler. Maybe we'll try again in the fall. But boy, I sure needed that mini break. So I hope some of you have been able to take that. There's so much going on in the world right now. I actually switched my Facebook only to my computer, so I cannot look at it on my phone. I've only given myself 30 minutes on Instagram every day because I just get sick of it. Now, if I could train myself not to look at Twitter, I'd be really good to go because that's where the depressing news is. So hopefully you can help me out with that and just be positive. And thank you for those of you that have been sending me just some really nice messages again on the CodeCast. I really appreciate that. So everyone, on this Terry Tuesday, thanks for spending some time with me. Make it a great day and a great week, and we'll see you next time on the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.